Hello, wellness friends. Today I'm very excited to introduce you to Dr. Victor Marwin. He is an orthopedic surgeon in Lexington at Bluegrass Orthopedics, and he specializes in upper extremity surgeries. And today we're going to talk a little bit about carpal tunnel and some shoulder issues and other issues that he'll get into later on. But Dr. Marwin, thank you for taking the time to meet with us today.
Thanks for having me.
And welcome to Lexington.
Thank you. Yeah, I see patients primarily in Lexington, but I'm also in our Georgetown office one day a week as well. So
Fantastic. So we're here today to talk to you about a technique that is for carpal tunnel release that doesn't require general anesthesia, and I guess you get your patients back to activity a lot quicker. So that's something kind of new. Can you tell me a little bit about what that technique is and how you utilize it?
Sure. Yeah, I've performed carpal tunnel releases most ways that are kind of acceptable in modern hand surgery. The traditional carpal tunnel release is an open procedure. It involves making a cut on the palm from approximately here to here through the skin and through the underlying soft tissue, getting down to the constrictive anatomic structure, which is the transverse carpal ligament. So the transverse carpal ligament runs across this part of the hand, and it's the constrictive anatomic structure in carpal tunnel syndrome. So everybody has a carpal tunnel. Carpal tunnel syndrome is when the pressure inside of that tunnel prevents blood flow to the median nerve. It essentially chokes off blood supply and oxygen to that nerve, and as a result, patients have numbness, tingling, paresthesias, that's the doctor term for kind of funny feeling in the fingers that can include burning, itching, and it's essentially it's nerve damage. So you're crushing that nerve, and as a result, that nerve goes to sleep. It doesn't work well. You can have ischemic changes over time, so that nerve can parts of it can kind of die and not work well, and some of these changes can be permanent depending upon how long they have carpal tunnel syndrome. But essentially, the pressure on that nerve over time is what leads to the symptoms of carpal tunnel syndrome.
Right. Can anybody get carpal tunnel syndrome? Are people more prone to it than others?
Yeah, it's more common in women.
Okay.
And it's typically, we typically see it as people age. We see it more commonly as people age. I will tell you, I've treated younger people in their 20s with carpal tunnel syndrome. It's more rare. My typical patient is typically 40s, late 30s, early 40s, up through any age. So it's more common as people age.
So if people are experiencing something with their hand and they're experiencing some numbness or pain or something like that, and you were saying that if you don't address it, the nerve can possibly die, or you can have some long-term or permanent problems. Is that correct?
You can. It typically starts off as milder symptoms, occasional numbness, typically activity related. Certain times when you're doing certain activities, it can be provoked. Typically wrist flexion and extension activities, sleep, nighttime symptoms. And the reason there is it's twofold. So it can be positional. So if you're flexing your wrist a lot and you're actually pushing that nerve against the ligament, you're increasing pressure on that nerve. And then when you go to sleep, your blood pressure goes down and the blood supply to that nerve decreases. So people feel the symptoms a little bit more when they sleep. As well, people can sometimes sleep in funny positions. They can curl up with a blanket and do one of these moves, and they're further compressing the nerve. So it's multifactorial. It typically starts off as milder numbness and tingling. That's intermittent, and then it can progress to more long-term daytime symptoms. People say, it happens part of the day, and then it's most of the day, then it's all the time, and numbness and tingling can progress to pain. And what that is it's really a progression of the compression of the nerve, and it's compression of the nerve over time. And as that happens, the nerve suffers more, and it absorbs more trauma, more of an ischemic injury, and some of it can be irreversible. In fact, if you ignore carpal tunnel for too long, you can start having muscle atrophy of the muscle of the thumb, and that is permanent. That typically doesn't come back. So
does carpal tunnel affect the entire hand or just certain fingers?
Just certain fingers. So it's the median nerve. The median nerve is the nerve that's compressed in carpal tunnel syndrome. There are other nerves that control sensation in the hand, but the median nerve is responsible for the sensation of the thumb, the index, the middle finger, and then half of the ring finger. So people will typically describe numbness in these three fingers, and they'll say, my ring finger a little bit too, but I can kind of feel over on this side. That's a different nerve. The ulnar nerve supplies the sensation to that side, and that's a different nerve.
Okay. So you were saying that the old way was making an incision from here to here. Now your way is not quite like that, correct?
Not quite like that. Yeah, and that's a very generous incision. I will tell you that traditionally, when this was done, in the 1960s, 1950s, certainly an incision like that, was not uncommon. You can look in the medical textbooks and kind of see massive incisions for this. It's shrunk to a mini open incision when we're talking about the open incision. It's typically from about there to there,
okay,
depending upon body habitus, the need for exposure, surgeon preference. So it's an incision. It's still relatively large compared to what I do. I've done many carpal tunnels through an open incision, but I do primarily minimally invasive carpal tunnel surgery.
Okay, so minimally invasive means just basically one opening, correct? Like a small puncture opening?
Yeah, it means, so I utilize a device, either an endoscopic knife or an ultrasound knife, in order to instrument the carpal tunnel from the inside. So when you're doing an open procedure, you have to get down to the ligament, which is the constrictive anatomic structure. So if you come from the outside, you have to go through the skin, through the subcutaneous tissue and the fascia to get down to the ligament. And you see that transverse carpal ligament, and then you divide it. And that's the constrictive structure in carpal tunnel. Endoscopic carpal tunnel has been around since about the late 90s, early 2000s. It was kind of popularized at that time. And that utilizes a transverse incision proximal to the carpal tunnel, so closer than the actual carpal tunnel, and allows you to get under the fascia and under the ligament and use a camera and a knife to cut the ligament from the inside. And when you cut the ligament from the inside, you're sparing the structures on top. So there's fewer layers you have to go through. It's minimally invasive by nature of the approach. And the reason why it was developed is, we thought, hey, can we get people back to activity faster? Can they have a quicker recovery? Can they have less pain? Because we're doing less damage in order to approach the thing that we need to release. And then there's newer technique, which I do as well, which is an ultrasound guided technique, which is a similar approach to the endoscopic technique, but it requires a smaller incision. And that's simply because the device is smaller. There's no camera. So an endoscopic technique utilizes a small fiber optic camera to be part of the knife and part of the device that goes into the carpal tunnel. Using ultrasound eliminates the need for a camera. The device is smaller, it's thinner, and that is actually done through an even smaller incision that's about 4 millimeters right in this area, and it allows me to slide a thinner device inside the carpal tunnel, and I use an ultrasound probe to visualize the structures.
So the old technique, people had a little longer of a recovery than the new technique. What is the kind of the difference between the recoveries?
Yeah, it's really variable. Traditionally, people and things that I've heard in my practice currently, people that have been indicated for an open carpal tunnel, their surgeon will typically recommend they take weeks off of work. And you have to understand the anatomy of the hand in order to really appreciate why that is. If you're making an incision, right around there through all the layers, this part of the hand sees a lot of stress. So when you're gripping, when you're manipulating things, the tendency is to try and spread this tissue. That the forces applied to the palm will sort of spread that. If you have an incision there, you have to take time off and really let that heal. You don't want to widen your incision. You don't want to put stress on those structures. You could have some delayed healing. The wound could break down. You could make yourself more likely to have an infection. By taking the incision and moving it off of the weight-bearing portion of the hand, back here in this area for an endoscopic carpal tunnel, or back here for an ultrasound-guided carpal tunnel, it really allows you to put your incision in an area that's not a weight-bearing portion of the upper extremity. So you don't do much with this part of your hand.
Right.
You're not gripping. It's out of the way. If you have to wash your hands, it's out of the way. It's easily covered with a Band-Aid. Most people have it covered with their shirt sleeves in this colder weather. So it's really not an issue. And you do have a little bit of soreness in the palm here because we are cutting the ligament, but the overlying structures, the overlying two layers, are still intact. So patients can get back to activities a lot faster. To get back to your original question, oftentimes I hear from patients that have come to me for a second opinion. They say, for instance, I had a young laborer who was in his early 30s who needed both sides done. And he saw a different orthopedic surgeon who correctly indicated him for carpal tunnel releases on both sides and said, you're going to have to take about 6 weeks off of work. And I would do one side and then I would do the other side. The reason it's really hard to have both hands bandaged,
Sure.
and have a fresh wound under there for self-care, bathroom purposes, things
Sure.
like that. It's kind of not something you want to do. So he would do one side, then stage the other, and he would need a minimum of 6 weeks off from work. This is a guy who worked in maintenance. He turned a lot of wrenches, used a hammer, things like that. And he just couldn't do it. And I actually did surgery on a family member of his who referred him to me. And we talked about minimally invasive techniques, and he had a week of vacation coming up from work. So we talked about doing bilateral simultaneous releases. And I will consider that for patients where that's kind of a necessity because of work needs or other needs. So I did both of his sides at the same time. His incision was back in this area, off of his hand. Really allowed him to have bandages here only, so he could still use his hands for self-care issues. And he, took a week off from work and recovered.
Wow.
And went back to doing maintenance work 6 or 7 days later. I will tell you that most of my patients that I do ultrasound technique on, I allow them to go back to normal activities as tolerated. So I typically, I'm a little more conservative. I'll tell them, take a day off, take it easy. They can use the fingers right away. So you'll have a bandage on for about 24 to 48 hours, and then you can take it off and wash your hand with soapy water. But I let them go back to activities of daily living immediately. So when they go home from surgery, they can use their fingers for putting their jacket on, for, moving a coffee cup around their kitchen, light sort of activity. Office work immediately. Higher demand physical activities within a couple of days.
Is this an outpatient procedure?
Yes, it's outpatient and hopefully soon to be office-based.
Really?
Yeah, here in the office.
Well, that's fantastic.
Yeah, in my training, we did most of them in the office.
Okay.
And it really is just a matter of getting the logistics together, but it's absolutely appropriate for the office. It's kind of the perfect procedure for the office. So patients can come in, have it done all under a local anesthesia. No need for general anesthesia, no need to stop anticoagulation, no need to stop any other medication. There's no need to have preoperative clearance. So patients that are more higher risk patients that have perhaps COPD or some heart issues, they're not being put to sleep in a hospital or a surgery center. They don't have to have medical clearance. It's kind of like going to the dentist. They're wide awake. They stay wide awake the whole time, and they don't really feel anything except for the needle going in to numb them up.
Can we control the pain with just over-the-counter meds?
Typically, yeah. So in most of my patients, over-the-counter anti-inflammatories such as Motrin and naproxen are appropriate, Tylenol as well. Some of my patients, I offer a steroid dose pack to decrease the post-operative inflammation if they can take steroids. And sometimes I prescribe an anti-inflammatory. I almost never prescribe narcotics.
Sure.
This. Yeah.
Well, you're being very humble, but I think that this is a bigger deal than people realize because you're that guy 6 weeks versus 7 days.
Yeah,
Is
or
that's
less than 7
well
days.
that's really for a lot of people that's a really big deal, and then not to be under the general anesthesia. A lot of people are frightened of that.
I agree. And look, my anesthesia colleagues will tell you that general anesthesia is safe, but and I agree. I put a lot of patients to sleep under general anesthesia for a myriad of other procedures that I perform. But it's unnecessary for this. You don't have to do it. Same thing with cutting all of the tissue in order to get down to the ligament. You don't have to do it. I don't have to hurt you that much.
Right.
I don't have to pump you full of chemicals to
Right.
have you go to sleep for it. So why do it, right? And then, 6 weeks off of work or 4 weeks off of work or whatever versus a couple of days, time's our most valuable resource,
Sure.
right? So my time's important, your time's important, everyone's time is important, right? It's the great equalizer is time, right? It's our most valuable resource, as I said.
That's
And
the commodity that we all have the same of.
yeah, or not the same.
Or not
but,
the same
But
of.
we just don't know how much we have. So I don't like to waste anyone's time. And if I can get you back to doing anything faster, I'm happy, right? So whether it's work, whether it's golf, whether it's caring for a grandchild, I have a lot of patients that are grandparents that have become nannies for their grandchildren,
Sure.
kind of like my mom did when I was a resident and a fellow. I certainly appreciate that. And no matter what the activity is, I like getting you back to stuff like that faster. And it's really satisfying having patients, the next day have their symptoms significantly better or gone. And then they tell me, I'm back to doing normal stuff. I have patients, tell me that they played in a golf tournament 5 days later,
Wow.
played 36 holes or, got back to work within a couple of days. I love those stories, so it's very rewarding.
Well, you actually brought in a couple of your tools that you use. Would you mind showing those to us, so that we can see actually how small or
Sure.
they are?
Yeah, I brought two of the minimally invasive tools that I use, and again, this is when I was talking about the camera device. This is a camera knife that I've used many times, and again, this comes in through an incision right here, and it slides into the carpal tunnel. And this allows me to instrument the knife from the inside. This is just the knife portion. This is a demo piece of equipment. A camera hooks up to the back of this in the operating room. So if I were doing this in the operating room, there'd be a big camera on the back of it that was fiber optic and hooked up to a high def monitor that allowed me to look at the structures inside the carpal tunnel. This is great. It's a great minimally invasive technique. It does require me to have a tourniquet on you, which is another pain generator. It's harder to do that in an office, although it can be done. And it's a little tougher for patients to tolerate because you have a pneumatic tourniquet squeezing either here on your forearm or here up on your bicep that's cutting off the blood flow to your arm. And the reason why you have to cut off the blood flow to the arm is so that I can see.
Right.
We're making a skin incision. There's going to be a little bit of bleeding, and that can obscure the view of the ligament. So the camera technique necessitates a tourniquet.
Okay.
And it can, it's only up for a couple of minutes. Patients can tolerate it wide awake if we kind of prep them for it. But it is another pain generator. It's another thing that we have to do. It's another factor in the surgery. But the ultrasound knife is another one that I use. This is what I use more often, quite honestly. I found that the outcomes are outstanding. The incision is smaller. People are thrilled with it. There's no tourniquet necessary. So I don't have to put a tourniquet on your arm at all. You can just have a local injection, be numbed up right here. You don't feel the incision when I make a little 4mm incision to put the device in. The device goes in kind of in the same area, and it slides into the carpal tunnel. These balloons, these clear balloons that you see here, inflate to move important structures out of the way. They move the nerve and the artery out of the way and create more space for a safe surgery. And then the knife glides in the path in a similar fashion to the other knife. But what this allows me to do is it with ultrasound visualization. So the key differences between these two techniques, with a camera, using a camera to look at the ligament that you're cutting, you don't directly see the other structures. You can see the nerve if you move the camera a little bit, but you typically don't see the other structures that you're on the lookout for or that you don't want to disturb, like the artery that is in the field, or the nerve that's next to the camera. Again, you can turn the camera and kind of look at it if you want to check the position, but it's kind of safety by exclusion. So you're just looking at the ligament. The great thing about ultrasound is that it really affords me a new level of safety. So I can, at the exact same time, look at the nerve, I can look at the arteries, and I can see the ligament in real time, all on the same monitor. Right. So it gives me a great view of every structure that I'm interested in, and it allows me to release the ligament well, and there are things that I check and I verify to make sure that the ligament gets a good release, and I feel very satisfied with it. And quite honestly, my patients are very pleased.
So once a patient comes to see you and you're going to do the procedure, actually, how long does the procedure last? Does it last a long time or not so long?
The length of the actual procedure. Yeah. The procedure itself is pretty quick. The procedure itself, if you wanna talk about the actual business of the procedure, it's about 10 minutes or so.
Wow.
The whole experience for the patient is a little bit longer than that. So the patient has to come into either the office or the surgery center. Right now I'm doing most of these in a surgery center. Again, we're trying to transition to the office, but and we will be actually running a pilot soon of doing certain patients in the office for a research project. But they can expect about an hour to an hour and a half experience by the time they come in. They do some paperwork, they check in, they get numbed up, they get in line, we get them into the room, we do their procedure, we wrap them up, and then since there's no general anesthesia, checkout is very fast. So as soon as they roll out of the operating room or the procedure room that we're doing this in, it's typically a quick couple of questions with a nurse, and then they're on their way. We don't have to wait for them to recover. Right. So they don't have to come out and void and be oriented. They already are. So and again, in the procedure room, the patient and I are typically having a good time. So
Sure.
it's another 10 minutes of face-to-face time with me where you pick out the music you want to listen to, and I put it on Spotify, and we're like having fun with whatever musical selection you want to listen to. We're chatting, we're talking about whatever you want to talk about. If you don't want to talk, we don't. Otherwise, I'm talking to you about your post-operative course, what you can expect, and things like that. And quite honestly, it's one of the most satisfying things that I do, because it's a fun time, and it's very, very fun for the patient too. They're any level of sort of anticipation and nervousness that they have typically fades away pretty quick when they realize that it's pretty cool.
Well, I think what our viewers can take away from this is that the anxiety level, when you talk about surgery, the anxiety level for a lot of people, just saying that word creates certain feelings of anxiousness. But it is a surgery, but at the same time, if you can say, well, we could potentially do it in the office, that's a game changer in my opinion.
I agree. It is and that's one of the goals here, is to decrease that anxiety level, right? So again, I do a lot of these in the surgery center. We're going to start transitioning to the office very soon, actually. And even if we were to do this in the surgery center with a patient, the level of anxiety decreases significantly. There's no anesthesia. There's not a lot of scariness that's typically associated with a bigger procedure. And research out there will show that a lot of people just don't have their carpal tunnel addressed. They don't want to see somebody for it because they're scared of the surgery. They're scared of a big approach. They're scared of post-operative pain. They're scared of being out of work. All those factors are mitigated by this. And these are the talks that I have with patients before surgery when they come and see me. And these are the talks that, these are conversations I'd like to have with people like you, right? Because these are the barriers to keep people from coming to see me. Sure. They may have had an aunt or some other relative or neighbor that, had a traditional carpal tunnel. They're like, oh, well, I had some pain afterwards and I was out of work for weeks. It's one of my favorite surgeries to do, quite honestly. Some people think it's boring doing carpal tunnels. I love it. Patients are very satisfied. I really enjoy them coming back and telling me how well they're doing. It's technically a demanding surgery the way that I do it. Not a lot of people have the requisite skill to utilize the ultrasound the way that I do. Right. And it was certainly there was a lot of education on my side of things that went into it, learning it from my mentors when I was training, and it's very rewarding though. It's become one of my favorite things to do.
But it's not the only thing you do, because
no,
you handle upper extremities. So we want to talk a little bit about maybe shoulder issues, shoulder replacement. There's new techniques in shoulder surgery as well. Do you want to talk a little bit about?
Yeah. So I am a hand and upper extremity surgeon. So if you want to simply talk about everything that I do, the best way to describe it is that I take care of almost everything from the shoulder to the fingertip.
Okay.
So I do shoulder replacements and shoulder arthroscopy. A passion of mine is shoulder arthroplasty, or shoulder replacements for older patients that have arthritis.
Okay. Do you have an age limit?
No, there's no age limit. No.
Because that's, a lot of patients go with a shoulder issue, and the surgeon will say, well, you're a little too old.
Yeah, I mean, for me, age is a number, and that's about it. There's physiologic age, there's chronologic age.
Bingo.
Those are different.
Absolutely.
So, an 80-year-old patient that is very active, or even I've taken care of. Again, this is not specific to shoulder, but even carpal tunnel patients in their 80s and 90s. That's not a no automatically. It really depends on the patient, and there's definitely benefits that even patients in those age groups with very profound disease can have with a surgical procedure. It might be different than the type of benefit they would get if they had surgery when they were in their 60s or 70s, but it's still an opportunity to make them better. And these are the types of conversations that I have with patients. But getting back to your original question, your original prompt, I take care of everything from the shoulder to the fingertip for the most part, right? So anything that would be seen in a private practice orthopedic clinic, right? So I take care of fractures. So if you have a wrist fracture or a forearm fracture, an upper arm fracture, I treat those. I treat arthritis, so worn out joints, specifically in the shoulder and in the hand. Nerve compression, like carpal tunnel. There's a couple other ones like cubital tunnel that I also take care of. Tendon problems, really, most things that people have wrong with their entire arm, I can take care of.
Well, we do want to talk about the
Sure.
shoulder arthroscopy, but you mentioned arthritis, and I just want to put something out there for our viewers. Is there anything new in the horizon for people with arthritis?
Sure.
Is there some things that you could talk to the
Yeah,
viewers about?
Sure, certainly. Yeah, there are a couple of new things that are kind of I guess kind of newer on the horizon, technologies or techniques really. As far as shoulder arthritis goes, the mainstay of treatment for shoulder arthritis is conservative treatment until it stops working, and then really when a joint is worn out, there's not much to do except for replacement, right? So arthroplasty is what we're talking about, kind of like replacing a hip or a knee. The shoulder's no different. The shoulder is unique in the sense that it has the most degrees of freedom of any joint in the body, and the reason why is because it's this highly unconstrained joint by the bony anatomy. It relies on the soft tissue to stabilize the joint. And that's the rotator cuff,
Right.
As well as the ligaments of the shoulder. So rotator cuff problems can exist, independently, and they can also exist with arthritis. And then you can also have arthritis without rotator cuff problems. So, there's a lot of different options for the shoulder depending upon, what the individual patient has going on with them. And there's two different types of shoulder replacements that are traditionally done that I do, and that is an anatomic shoulder replacement and then a reverse shoulder replacement. I can get into the differences on those and sort of some of the newer techniques that we use for those as well if you want.
Sure. What would be, as a physician looking at a patient, is there one that seems to, as far as the outcomes go, is there one that seems to do a little bit better than the other, or is it patient dependent?
Yeah, I'll tell you the best outcomes are for an appropriately indicated surgery. So, you're going to have your best outcome with a surgery that is chosen properly for you. So, not everyone will do better with one versus the other. It really depends on your pathology.
Okay.
And it comes down to the rotator cuff. It comes down to whether or not you have a good functioning rotator cuff. If you've got a good functioning rotator cuff that's strong and pretty much free of significant disease, an anatomic shoulder replacement is going to be a great operation for you if you've got bad shoulder arthritis. And I'll explain what I mean here. So this is a shoulder model, and if we're talking about an anatomic replacement, I'll actually use this one. This is our I don't think that'll sit back on there, but I'll hold it.
So that's the humerus.
Yeah, this is the humerus and this is the scapula. So an anatomic shoulder replacement recreates the natural anatomy of the shoulder. Okay, so when we do an anatomic replacement, loose model, we're replacing the ball on the humerus with a metal ball. So here's a metal ball, and this is a stemless system. And then we also have a stemmed system here. So you can either have a stem that goes into the bone or something without a stem. You get to the same place, but it's a different technique. And you put a metal ball where there was a bone and cartilage ball, and then the cup side or the glenoid side is a plastic cup instead of the native bone. And what you're doing is you're resurfacing the joint. So you're resurfacing the ball side and the socket side. And this construct right here, this surgery, it's dependent on an intact rotator cuff. So the rotator cuff muscles live on this bone, the scapula bone. They live over here and then they connect to the humerus. And what they do is they lock this fulcrum. So they will keep this locked right here so that you're able to raise your arm up like that. If you don't have an intact rotator cuff, this head will slide around and be sloppy, and it'll bang into this other bone here, the acromion bone over here, and the coracoid. It'll hang up on these bones, and actually there's not a ridge of bone that's normally here on this model, but and the shoulder won't work well. You won't be able to lift your shoulder up like that. Your arm won't go up because the mechanics of the shoulder are altered. If that's the case, if you don't have an intact rotator cuff and you have shoulder arthritis, or you have something called rotator cuff arthropathy, which is arthritis from not having a rotator cuff, a reverse total shoulder replacement is the operation for you, and I'll show you what that looks like. So we'll switch out our model here. And it's called a reverse total shoulder replacement because the polarity of the joint is reversed. So essentially we take the socket side and we put a ball there, and then we take the ball side and put a socket. And what that allows us to do is achieve good shoulder motion without a rotator cuff. So by putting this glenosphere or this ball on what is traditionally the socket side, the normal anatomy, it's the socket side, and then putting our cup on the humeral side, it allows the deltoid muscle up here to be able to take over and raise the shoulder.
So you can have rotator cuff tearing and do this surgery, and your outcome could still be
You could have
quite
no
good.
rotator cuff. You could have zero rotator cuff, a rotator cuff that is essentially non-functional in patients with very profound rotator cuff disease, where they've had long-standing rotator cuff tears, rotator cuff atrophy, a rotator cuff that, for all intents and purposes, doesn't really work. And it'll allow them to go from a place where they're doing this with their shoulder and they cannot elevate it to getting above the horizon line and getting their arm really up above that 90-degree mark. So for me, it's important for a patient who has rotator cuff arthropathy or a really bad rotator cuff that doesn't function well and concomitant arthritis, where they're doing one of these and they just can't get their arm up because the rotator cuff doesn't work for those reasons that I said. And I get them above that 90-degree horizon. And I get them to the point where they can get something off a shelf. They can reach that, the cabinet above their refrigerator.
Sure.
They can, simple things. They can get their arm into a sleeve better, things like that. They can touch their face.
The old jacket thing. And
yeah, that's a tough move to get. even with a reverse, with an anatomic shoulder, that rotating behind the back that motion's a little bit better because the rotator cuff is intact. Patients that have a reverse typically don't get really good behind the back motion. That's just something that, based on the nature of their pathology, we can't really recreate. So I always tell patients that reaching behind their back may not get any better with a reverse, but it's already bad in a lot of those patients. And the goal really is to get them good forward elevation. And this is a motion called abduction, where we get them sort of out here, right, instead of like this, where they can't do that. And that's the goal of surgery. That's the improvement that we're looking for.
And just for our viewers, there's a rotator cuff and then there's a rotator cup, and people kind of get confused. And the rotator cuff is actually more than one muscle.
So when people say rotator cup, it's actually a misnomer. They're referring to the rotator cuff.
I guess the labrum is
the labrum is a separate structure,
right?
Which does the labrum is we don't really have a labrum on this, but if you can kind of think about the edge of this glenoid right here. So this is the cup. This is the plastic cup that we put in when we do a shoulder replacement. And if you look at the rim of this, that's where the native labrum sits. Right. The labrum is kind of like the bumper on a pool table.
Right.
It's a cartilaginous ring that deepens the socket and confers some more stability in the native shoulder. The rotator cuff, here, I'll pull this off and we can kind of talk about it. So this is the scapula. The rotator cuff muscles, there's four of them. And essentially, without getting too deep into the anatomy or the specifics, they live on this bone, both on the front and the back. And they fill out these, we call these the fossa of the scapula. So this little space right here is filled with a muscle. Same thing in the front and the back, and they live here and they kind of cross over. The tendons come over and they attach to the humerus. And again, what it does is if my fingers are the tendons and my hands are the muscle, what they do is they keep the head centered on the cup and allow that arm to really rotate.
Right.
And those four muscles working together stabilize the shoulder. And typically people will have a tear in one or more of those tendons.
Right.
That forms the rotator cuff tear. Some more common than others.
And it's a fairly shallow joint anyway, so you really...
Yeah, people think of the shoulder like a ball and socket. It's not.
Yeah.
The hip is more of a ball and socket. The shoulder, it really looks like a golf ball sitting on a golf tee. If you want to think about it like that.
Yeah, that's great.
If here's the glenoid right there, that's your golf tee, and then there's your golf ball, and it really just sits on top of it like that, and there's not a lot of bony support, right? So it's a very shallow, small cup, and the head is big, and we really rely on other factors to stabilize the glenohumeral joint or the shoulder joint, and that ends up being the rotator cuff muscles. Those are the dynamic stabilizers, meaning they can change their length and change their characteristics to stabilize the shoulder. And then there's the ligaments of the shoulder. And the ligaments are more static stabilizers. They don't really change that much, but they're very important to stabilizing it.
So we talked a little bit about the carpal tunnel, but in your shoulder replacement, I assume it's done in a surgery center under general anesthesia, a little more involved, and recovery a little longer.
Yeah,
on that
surgery
as well.
center or a hospital. Sometimes inpatient. Sometimes it requires an inpatient stay for a day, depending upon the patient, depending upon their medical issues. It's typically performed, it is performed under general anesthesia, typically with a block. So most patients will get a nerve block, which decreases their need for anesthesia during the procedure. It helps with their post-operative pain. Usually they're numb for a couple of days afterwards,
Right.
So it really helps with that. Some patients, appropriate patients, can be done in the surgery center safely and then discharged the same day. Kind of like people who've had hips and knees done in the surgery center, same idea. The nicer thing about the shoulders, you don't walk on your arm, so you can have it in a sling. It's a little bit easier to sort of get out of there if you have an ambulatory surgery.
And recovery time on that, I know it's
Yeah.
patient dependent, but it's
it is patient dependent, and it's really how you define recovery time. What I like to say is that, by about 6 weeks, patients are feeling pretty good, using the arm, for a lot of activities of daily living, kind of really starting to move it a lot more. And then at 12 weeks when they come back, they're pretty happy. They got pretty good motion overhead. Their pain is, minimal at that point.
Is physical therapy something you utilize with
Not typically.
Okay.
So physical therapy is not necessary for every patient. It is for some, especially if people are having some difficulty on their own. A lot of patients typically will have a therapy instructions that are given to them. We have them do some pendulum exercises where they're
home exercise.
Yeah, rotating the arm and then using the arm for activities of daily living and really avoiding certain things is important. So if you have an anatomic shoulder replacement, we have you avoid certain activities because we repair the tendons. So we hold you back a little bit more. So the anatomic shoulder replacement is a little more restrictive in its post-operative restrictions.
Right.
The reverse is not. The reverse, they can kind of do most things pretty quickly.
So they're in a sling for a little while, but then they can start.
Weeks.
Okay.
Sure.
Is there anything else that you do for shoulders? There's something called PRP out there. Is that something that you've heard about?
Yeah, I used a lot of PRP previously in my career.
Would you tell people what that is?
Sure, yeah. PRP stands for platelet-rich plasma. It's an autologous preparation that comes from the patient, meaning it comes from your own body. So PRP is acquired by doing a blood draw. We draw your blood, we spin it down, and the liquid portion that comes off of that is the PRP. It gets prepared, and then we will re-inject that for certain conditions. It's typically indicated for things like tendinopathy, so like patellar tendinopathy, Achilles tendinopathy. It's been used off-label for some other stuff. And the idea there is that it contains the sort of these healing factors that sort of help to coerce along, soft tissue healing.
Have you had some success with it?
I typically don't. I have previously.
Okay.
I don't really use it that much now for a lot of the stuff that I do. Prior to being an upper extremity surgeon, I was a general orthopedic surgeon. I took care of more lower extremity stuff. I took care of, Achilles tendons,
Sure.
and patellar tendons, and now I focus more on the hand. And there's limited indications for it in what I do right now. But I certainly have had some good experience with it in limited fashion previously, but now it's not really a big part of my practice.
So 3D printing is something that I've heard or read about. Is that something that you think is viable for the future for some of what you're trying to do?
Yeah, absolutely. There's actually a new shoulder system that's on the market. It's a relatively recent entry that the components are actually 3D printed. So every component is 3D printed in the factory where the company makes it. So there's a lot of uniformity there because they're able to really highly control exactly what the implant looks like, and the bone ingrowth surface is 3D printed. So it theoretically makes it a more successful ingrowth surface. Currently, there's 3D printing technology for really complex shoulder problems. So if you've got a really arthritic shoulder with a lot of deformity, some of the companies that I use will 3D print a custom jig that allows us to really place our hardware in a better position. So what they do is they'll actually take your CT scan of your shoulder, which will look like this in a 3D model, and then we'll upload it to a computer system that allows us to virtually position the implants preoperatively. So I do that for most of my patients. So I'll take your CT scan, I'll upload it to this program from the manufacturer, and it allows me to sort of move this stuff around in virtual space in the computer program. So that's not 3D printing, but that's essentially like a 3D technology that allows me to preoperatively plan. And then if necessary, if you've got a pretty complex shoulder, we can 3D print a jig that I can actually use sterile in the operating room that'll allow me to place your hardware in an optimal position.
Wow, technology.
Yeah, I think the next step is going to be more 3D printed implants,
Right.
and more customization.
Where it's more like the joint that God gave you. You know. It's
Yeah,
more,
well, for highly complex joint pathology, there are custom implants, and these are very specific things. I use them a couple of times in my training. Again, these are rare cases that luckily, because it indicates people have really bad pathology. But in rare instances, we have to take somebody's CT scan and create a custom implant where the metal is actually formed to their deformity,
right.
because they have such profound bone loss. And that's something that is a combination of 3D printing and other types of fabrication technologies from the company where they come up with a custom implant for you.
Have we gotten any closer to cartilage regeneration? Is that
No,
something that's...
Not really.
You know,
Yeah, not
what's
really.
what's your opinion about that? With
It'd be great.
I mean, stem cells and stuff. I mean, are we?
Yeah, there's nothing that to my knowledge that is currently.
Is that a holy grail kind of thing? If a doctor could.
Yeah,
help.
well, the person that figures that out will be wildly successful, right? So there's I did some research on this back when I was in medical school about what happens to cartilage with post-traumatic cartilage loss, and really that's still a nut that people are trying to crack. There's nothing that is FDA cleared to use in the United States that can restore cartilage in arthritis. We can do cartilage restoration procedures certainly for traumatic cartilage injuries. So this is the young athlete that has like a big cartilage flap that gets knocked off because they have an injury. We can do cartilage transplantation. There's some technologies where we can harvest their cartilage from a non-weight bearing part of their knee, and we can either reimplant that in a different part of the knee, like take a plug and put that in, or we can harvest it, send it off to the lab, have them grow it, their own cartilage in the lab, and then reimplant that patch. Those are some things that I've done previously, but nothing to the point where we're injecting something and it's kind of growing back cartilage. It's a hard problem because you have to understand that when the joint destruction that takes place with arthritis happens over decades. And it's not just that the cartilage is gone. The cartilage is not just scraped off like a road that needs to be repaved with a new surface of asphalt. The joint mechanics are altered as well. There's deformity to the joint. There's osteophytes. The underlying bone underneath the cartilage is changed. There's subchondral cysts, meaning there's holes in the bone that are filled with fluid. It's a spectrum of different problems that is not just addressed by putting the cartilage back. Now, I mean, who knows what the next 20 years are gonna show us? There may be some crazy technology that like I can't even possibly think of right now that,
Sure.
that will allow these cells to reprogram themselves and become young again. There's nothing on the near horizon that I'm aware of.
It's too bad.
Anything comes close to that. Well, it's good for me because that would put me out of business as an orthopedic surgeon.
That would be okay though.
No, it'd be good for patients. It'd
Yeah.
be great for patients. It'd be awesome.
For humanity's sake, that would
It'd be great for humanity. Yeah, that would be.
Do you do any techniques for the thumb arthritis?
Yeah, absolutely. Yeah, I do a couple of techniques. We can start off with non-surgical things such as bracing, anti-inflammatory use. Steroid injections work well to sort of buy people time.
Right.
Ultimately, arthroplasty for the thumb is the surgical choice. So there's a couple of different techniques that you can do. So taking the arthritic bone out and creating a space, which is called an interposition arthroplasty. That's something that I offer. That's kind of more of a gold standard treatment. There's other implant options. There's a metal implant option that works well at preserving grip strength for the right patient. So if you're kind of a younger person with thumb arthritis and you still need to rely on grip strength, when you have that thumb bone taken out, sometimes you don't have good grip strength afterwards. Your pain is relieved, but sometimes grip strength is a problem, and that's not typically a problem for a lot of patients that don't rely on it. They just want the pain gone, and that's a great surgery, and I do mostly that surgery. Sometimes, again, for the right patient, replacing that thumb, the arthritic joint with a metal implant can relieve a lot of their pain and still preserve their ability to grip.
Great. Obviously, we could go on and on.
There's a lot of things we could do. We could also, and again, we could have another session where we cover other things that you
Absolutely.
I'm
but
happy to always talk.
I know you're a very busy person, but anybody out there that has some of these issues that would like to talk to Dr. Marwin, we're going to put all your information in the description below this video so they can find out where you are and who they need to contact. So all that'll be there.
Yeah.
But
my website is a great option. So the Bluegrass Orthopedics website has all of my contact information on it, and then there's another website, Dr. Marwin CTR. So just Dr. Marwin Marwin, and then CTR for carpal tunnel release.
Okay.
.com. That's another great website to use as well.
Okay. So we'll have all that information for you to get in touch with Dr. Marwin. But thank you so much for your time.
My pleasure.
Listen,
Thanks very much for having me.
Okay. Thank you so much.